All right, guys, happy Monday. Welcome back. DENT 3500. Complications C. We're going to be talking about infections, dry socket, some nerve damage related topics, and then we'll wrap up this topic of complications. This is an unfortunate patient with an infection associated with the right face. You'll see on the next slide, more specifically, some of the spaces that it's involving. Here you can see this dark area surrounding the right ramus. And I say the right ramus, so this is an axial slice looking up from the toes of the patient. So you can see collection of exudate or pus underneath the masseter, so submasseteric, underneath the mediopterygoid, so pterygomandibular space, as well as along the lateral pharyngeal space, which extends from the hyoid up to the base of the skull anteriorly. It's defined by the pterygomandibular raphe, medially by the superior constrictor, laterally by the medial pterygoid, and posteriorly by the retropharyngeal space. So you can see it's pushing the airway over and partially occluding it. So this is an emergency. Need to go to the OR right away to establish drainage and secure the airway. When it comes to post-op infection, the incidence is going to vary based on a lot of the variables at hand, the difficulty of the extraction, the experience of the person doing the extraction, and a lot of patient factors. Is the patient immunosuppressed? Are they diabetic? Are they taking steroids? Are they a smoker? A lot of variables at play. Overall, typically the incidence is 5% or less. Like with most things, prevention is key. Exercising surgical asepsis, considering pre-procedural mouth rinses, minimizing tissue trauma, copious irrigation and debridement, and prophylactic antibiotics if immunosuppressed. When it comes to third molars, we will certainly give 2 grams of amoxicillin or 600 milligrams of clindamycin preoperatively, as it's been shown to decrease the likelihood of infection, as well as dry socket. At the end of the procedure, we always carry out a thorough debridement and irrigation to remove any bone dust or any potential tooth or enamel fragments in the socket or under the flap. And this is a very important part that doesn't take very long but can go a long way with respect to prevention. The biggest variable associated with post-op infection is length of the procedure. So this is why you want to spend time getting good at these procedures, knowing that the amount of time it takes you to carry out the procedure is directly correlated with post-op complications, likelihood of infection, and post-op pain and swelling. With respect to management, obviously starting off with the correct diagnosis is paramount. Certainly after post-op day 3, the patient should be getting better with decreased pain, decreased swelling. Any increase in pain or swelling, the patient is encouraged to return for reassessment at your clinic. If on exam there's increased swelling visible with redness and pain to palpate, it's most likely an infection. When I see these patients back, it's typically lower teeth that are way more likely to get infected. So what I'll do is I'll obviously examine all the teeth, because certainly upper teeth can be infected. But with lower guys, what I'll do is I'll sort of stand at sort of a 10 to 12 o'clock position and palpate over the lateral aspect of the body of the mandible angle, depending on where the tooth was, looking to detect, obviously for a subtle infection or early infection, a little subperiosteal collection. And you'll often feel it with your thumb, and as soon as you get to that area, it's just like a little bump, and the patient will kind of jump, and you say, aha, and there may or may not even be frank purulence coming into the mouth or through the socket. Certainly if you see frank purulence or exudate, also known as pus, this is a classic sign of infection, and then you decide what to do about it. It could be simply irrigating out the socket and covering them with antibiotic. If you think you've caught it in that first 2 to 3 days, you could consider monotherapy with something like amoxicillin. But after day 3, there's often a significant anaerobic component, and you'll want anaerobic coverage. So either amoxicillin and flagyl, penicillin and flagyl, or clindamycin by itself are all reasonable choices in that scenario. If the infection doesn't go away with a course of antibiotics, you certainly would consider reopening up the surgical site and establishing drainage. I also want to be thinking, is there another source here? Is it the tooth we took out? Or maybe there's a new kid on the block, the neighboring tooth that was planned for restoration has actually gone necrotic. So always consider repeating your Panorex and considering vitality testing of the adjacent teeth in the area, just to make sure you don't have tunnel vision and you're focusing on the recent extraction that was done. Typically that is the source of it, but just always good to be thinking and open-minded. So when do we refer our patient that we think has infection into the hospital? So certainly if the history discloses a rapidly progressing change with the infection, so they say I woke up this morning and kaboom, had this big swelling, whether the source is still there or whether it's a post-op infection, rapidly progressing infection would be a danger sign and a good indication to refer them in. Rapid onset of significant infection, sort of similar, same but different. High fever. Fever certainly can be associated with infection. Typically isn't with odontogenic head and neck infections for whatever reason compared to a pneumonia or skin and soft tissue infection associated with, say, a diabetic foot. So a fever is a very big red flag. You want to admit that patient into the hospital and get them going on some IV antibiotics. If the patient is unable to handle their own secretion, so their saliva, that's a big concern with respect to their airway. It speaks to the difficulty of swallowing, which will speak to the location of the infection, typically in your masticator space and or lateral pharyngeal, retropharyngeal. Certainly needs admission, IV antibiotics, incision drainage, and source control ASAP. Not responding to appropriate antibiotics, sure. Say they're penallergic and they're on Clinda, we know that there's certain bacteria like Echinella corrodens that clindamycin doesn't cover. So you'd have a patient on a very appropriate course of clindamycin that's not responding. Reasonable to refer that patient for culture sensitivity and switching up the course of antibiotics plus or minus admission. If the infections involving major spaces, absolutely. So, any patient with limited opening, trismus, it could be involving, one of the masticator spaces. So, submasseteric, pterygomandibular, infratemporal, deep temporal, superficial temporal, or certainly lateral pharyngeal would all be major spaces that would be of significant concern and require admission. Compromised host defenses, so simply patient being diabetic, this would count. Doesn't have to be somebody that's undergoing chemotherapeutic treatments, for instance. Smoking also makes you immunosuppressed. The majority of our infections, I'd say 99%, are either diabetic or smokers, ones that get admitted. It speaks to the immunocompromised state that they're in. Poor compliance, bit of a weak reason, but certainly if a patient can't be trusted or they're not taking their own oral antibiotics home, then certainly admission for some IV antibiotics would be a consideration. Unable to maintain adequate nutrition, hydration, absolutely, for obvious reasons. We're no longer comfortable treating, hopefully by educating yourself, reading the chapter in your textbook by Hupp on infection, Seeing these patients over time, you'll develop a sense of an infection that's appropriate for you to keep in-house and follow up in your own clinic after 4 to 8 hours to make sure they're getting better, versus one of the patients that has one of the things in this list that would warrant picking up the phone, speaking directly with your local oral and maxillofacial surgeon with admission privileges, and discussing the case with them, and then deciding on their further management. Post-op infection is one of the risks, of course, that we quote patients prior to third molar removal. The reality is, if a patient like this doesn't get the tooth out when it's asymptomatic, it's a very high chance of this tooth either getting caries itself, causing caries on the distal of the sevens in front of them, or developing pericoronitis over top of the operculum covering the distal aspect of the portion of the tooth that's still impacted. Here you can see pericoronitis associated with impacted tooth 3-8. Not the greatest picture, but you can certainly get a sense of that boggy pericoronal operculum type tissue overlying this tooth. This certainly needs to be extracted ASAP as far as etiology goes, and covering the patient with antibiotics in an empiric fashion to try and minimize the likelihood of the infection continuing in a post-op setting. Here we can see pericoronitis associated with impacted wisdom tooth 4-8 that wasn't taken out in a prophylactic fashion. So this patient needs this tooth taken out ASAP, incision and drainage, and coverage with at least a week of antibiotics and regular follow-up to make sure that they're getting better.
This is a super nice guy. Unfortunately, had it sounds like pericoronitis associated with tooth 4-8. Also had necrosis of tooth 4-7, and you will see that often in cases where the wisdom tooth didn't come out in time, and they have poor oral hygiene in the area because it creates a food trap, and you'll get deep caries on the adjacent 7. So often removal of the third molar is a tooth saving or tooth sparing procedure because it allows them to take proper care of their 7s and keep them the rest of their life. This guy unfortunately developed a life-threatening infection involving multiple spaces, mostly the submandibular space, but certainly buccal, lateral pharyngeal space as well, threatening his airway. Luckily, he came to see us in time, went to the OR, went to sleep, and underwent extraction and incision and drainage, which you can see in the upcoming video, which you guys are the first class to ever see. Put this together especially for you. Hopefully you don't find it too gross. It's just a fantastic example of what can go wrong if you don't get those teeth out in time.
Yeah, there's head, chin, submental, and then show the incision line, the plan. Good? Okay, go ahead, Alero. And back up a little bit. Make sure you got a good view there, James.
Yeah.
Good. Good. Okay, pause there. See that, James? See
Got
it?
it.
You getting it?
Yep.
Suction up more. Doing it for the video, Alero, if I do too good a job. So now we're going to switch to the Kelly. So you're going to go up towards the mandible with it, you know what I mean? Like in and up.
Yep.
And interior, like towards his molar, pictures, exactly. It's a nice safe place there. Good, 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 careful. And now open up the beaks.
Not a mandible yet.
It's okay, open up the beaks. Just a bit, yeah, good. You get that, James?
Yeah.
Wow, sweet. That's good, don't need to open anymore. Oh wow. Oh wow, wow. YouTube.
All right, so fantastic. Very recent example of incision and drainage through an extraoral approach in the OR under general anesthetic to drain a life-threatening infection in the submandibular space. This was of odontogenic source, from the posterior right mandible, associated with both partially erupted tooth 4-8 as well as carious tooth 4-7. This gentleman would have been admitted with Penrose drains on IV antibiotics for about 5 days afterwards, and he got better really quickly with this very appropriate treatment. So here you can see once the dust is settled, a couple of Penrose drains. These will allow any new exudate that gets formed to drain out of them, as well as a portal to irrigate sterile saline through as the patient's getting better. Each day you'll slowly advance the drains and pull them out until the point that they're completely out, in keeping typically with the patient progressively getting better. Rarely does the patient have to go back for an additional washout in the OR. This patient responded to this washout as well as the IV antibiotics and several days stay in hospital. Dry socket, the other thing we certainly warn people of after having any tooth out, certainly wisdom teeth. Relatively common. The pathogenesis not fully understood, thought to be sort of premature breakdown of a formed clot, causing new onset of pain at 3 to 5 days after the extraction. Causes can be difficult surgery, bacterial contamination, prolonged surgery, which goes hand in hand with difficult surgery. Smokers, birth control pill, third molars are more common than other teeth, and advanced age. Beautiful table here to memorize, just comparing, contrasting, abnormal pain versus dry socket versus infection. So with all of them, of course, you have pain. That's what gets them in the door. Then what's next? Fever. Most of them honestly won't have fever. Rare for an infection to have fever, but certainly dry socket won't. Abnormal pain won't. Infection might have fever. Onset with abnormal pain, typically more immediate, and they just aren't coping well right from the get-go, right from day one once the freezing comes out, and it never goes away. Certainly eventually should go away, but is there as soon as the freezing comes out. As opposed to dry socket, they're putting along doing pretty well, and then day 3, new onset of pain. Infection, I say, can be right away, sort of the same time as dry sockets, day 2, day 3, or it could be several months down the road. Point is, if it's dry socket or infection, they were doing okay and then they got worse. That's your ticket to get in for an immediate post-op visit. Swelling, shouldn't have swelling with abnormal pain or dry socket, and most likely will with an infection, anywhere from mild, moderate to severe, depending on the severity of the infection, obviously, and the location. The socket and abnormal pain will just look completely normal because it is normal, it's healing, they're just abnormally painful or low pain threshold. Dry socket, it could be abnormal or empty. Versus an infection, you'll often see pus or exudate in the socket. Looking in the socket, it's pretty low yield. Certainly if you see pus, then you can say, yeah, infection. But saying it's empty with dry socket, I find it's pretty low yield. Often the gum's kind of collapsed over. It's tough to see in there. So this is sort of a low yield finding, sort of staring down the socket. But certainly you want to look in there to see, at least if you can see exudate, to push you towards the likelihood of diagnosing it as an infection. Erythema, won't have it with abnormal pain, won't have it with dry socket, frequently will with infection. So just a super important table to keep things nice and clear in your mind. People coming back with post-op problems. It's not a bleeding problem, it's a new pain, and you're just trying to triage in your mind, is it a dry socket or infection, or is it just normal healing and they just need more analgesics? Things we can do to minimize dry socket: atraumatic surgery, thorough rinsing of the surgical site. Preoperative antibiotics actually does help prevent this, and this is exactly why I give them. 2 grams of amoxicillin or 600 milligrams of clindamycin has been shown to decrease dry socket. Tetracycline in the socket, this would be sort of in place of a preoperative oral antibiotic. Chlorhexidine rinses, I give those to everybody afterwards as well, primarily to prevent dry socket. And smoking cessation, everyone knows they should quit. Smokers are way more likely to get dry socket, so this is sometimes a good excuse for them to quit. So patient comes back, you've diagnosed him with dry socket, what do you do? Pain control is the mainstay. I always say if you're on a desert island with a dry socket, you'd be fine. It just wouldn't feel that good. It is self-limiting. It will go away. Unlike the untreated infection, which can lead to death, dry socket will eventually get better. It sometimes can take a while, up to 10 to 14 days. So the mainstay is pain control. So this could be increasing perioperative pain control, optimizing your analgesic ladder, your NSAIDs, your acetaminophen, as well as a narcotic until things are under control. The other option is to put medicated packing in the socket, which is tempting. It can give instant relief if you put it right down at the bottom, but it does need to be rinsed out at a later date, and it could potentially increase the likelihood of developing an infection because you're putting a foreign body down in the socket.
Damage to nerves. Certainly a big source of litigation against dentists. Very frustrating for all involved, patient, practitioner, and it could involve one of multiple nerves. Certainly the inferior alveolar nerve, but it could be the lingual, mental distribution of the IAN, the long buccal, incisive nasopalatine, greater palatine, or even the infraorbital. This could be caused by injection injury from your local anesthetic, an incision with a 15 blade, a traction injury with your Bishop's or your Minnesota retractor, surgical burr like your 701 or your 8 round, a crush injury, or a suture. Nerve damage could just be temporary, but it certainly could be prolonged, or even more rarely permanent. It could present as paresthesia, so altered sensation, anesthesia, which is the complete lack of sensation, or dysesthesia, which is a painful sensation in the absence of a painful stimuli. Injection injury, luckily fairly rare. Range quoted in the literature, typically closer to 1 in a million, but certainly possible. Potential causes could be direct damage by the needle. This is rare. Typically, I think as you're going in, let's say for an inferior alveolar nerve block, what happens is the neurovascular bundle will kind of roll out of the way. Just like when we're trying to start IVs, if you don't put traction and immobilize the vein, it will sort of roll out of the way. And I think this is what often happens when we're going in, trying to get it close to the mandibular foramen, and the nerve will sort of move a little bit to help us out. But when all the stars malalign and you go right through the nerve, the patient cannot help, even the best patient, except have sort of a jump or a jolt, almost like an electrical sensation. And when you see this, you need to stop, withdraw the needle, and perform your block in a new location. The last thing you want to do is inject directly into the neurovascular bundle, as this can be neurotoxic. You can also cause a hematoma of a neurovascular bundle just by nicking either the artery or the vein, which will cause a bleed into the area, which can put pressure on the bundle, causing ischemia and potential damage. So like I said, if you don't want to inject, if you think you're in the neurovascular bundle, and if you do nick the bundle, use a different technique. Say you're doing a traditional block, maybe try gow gates, go up a little higher to a new location, and try your injection there. Incision injuries, there's no excuse for these. We've talked about these in a standalone lecture discussing flap design. Essentially, you have to know where these nerves are, mental foramens. You don't want to do any releasing incision in the premolar area. When you do a releasing incision in the molar area, you do it in a distal buccal fashion so as to not go out the back and drop off the lingual aspect of the ramus, incising the lingual nerve, etc. You don't want to transect or incise through your nasal palatine or your greater palatine nerves. So basically avoidance and prevention when it comes to preventing incision injuries. No excuse for these. Just a little diagram showing why you need to go distal buccal. When you have your hospital rotation, you'll see us all removing third molars
with a distal buccal release, just like the dotted black line that you see here over the buccal shelf, as opposed to going straight out the back where the red line is, where you're high risk of injuring the lingual nerve. And once again, early on, these things seem confusing, but they're really not. You got to know where the nerves are in the maxilla, in the mandible, and don't cut through them. So last thing you should do would be do a releasing incision in the premolar area. You're very high likelihood of incising through the mental neurovascular bundle main hub or one of the branches going to the gingiva, the lip, and or the chin. Very easy to avoid. Essentially, you'll do a sulcular incision, and if needed, you could do a release back in the molar region, or more rarely anteriorly in the incisor region. Certainly, I will do releasing incisions in the area of the 6, 7, or 8 on a regular basis as a 3-corner flap, giving you fantastic access to this premolar area without compromising the mental foramen and the associated neurovascular bundle. Traction injuries, I think, are one of the more common ones, just because people aren't thinking about what's going on with their left hand, the hand that has the Bishop's retractor or the Minnesota or the periosteal. They're so focused on their right hand, the one that's extracting the tooth with a forceps or using the 701 bar, and they forget after they've made this really nice flap that now their Bishop's is pulling down on the flap and crushing the mental foramen, for instance, or over-aggressive lingual retraction, for a third molar if it's a tough case. They're so focused on the hard tissue aspect of the case that they're neglecting the soft tissue management. So at no point should you be pulling hard on these soft tissue flaps. Typically you're resting your instruments on hard tissue as opposed to pulling apically, where you're more likely to cause a nerve injury. Surgical burr injuries are another option, not an option, a potential source of injury to nerves and neurovascular bundles. Certainly this third molar would be at increased risk compared to a third molar that's not sitting directly on the inferior alveolar neurovascular bundle. And we have ways to help minimize the likelihood of injury to the neurovascular bundle, typically around perioperative planning and imaging. Certainly when you're removing a third molar like the one in the previous slide, one must be careful not to drill too far lingually or medial, as the lingual nerve is just on the other side of that thin lingual plate. So for instance, when you're segmentalizing a third molar, you typically won't go 100% of the way through. You'll go 90% of the way through and allow your 77R to split that remaining 10%, thereby minimizing the likelihood of a lingual nerve injury. Same as the inferior alveolar nerve. You know where it is based on your x-ray. At no point should you drill all the way through the tooth, down into the inferior alveolar nerve. Or if you're making a trough, same thing, you want to make sure you get down to the CEJ, and typically no need to go further, too deep a trough, depending on the location of the nerve, you could be drilling right into it. Mental nerve, once again, it's all about perioperative planning, knowing where it's at and avoidance, making sure that you're protecting it with your retractor and not traumatizing it with your retractor. Nowadays, when we see a third molar traversing the inferior alveolar neurovascular bundle, we'll request CBCT for three-dimensional imaging just to get a good look and see where exactly is the nerve in relationship to the root tip. Is it on the buccal? Is it on the lingual? Are the roots entrapping the neurovascular bundle? And it really just helps with planning. If you run into the scenario where you have to remove a root tip, you'll know where it's safe to drill and where it's not safe to drill. This is our CBCT over at the VG hospital. I'm sure Dr. Gregoire, I believe, still gets students to come over and view it in person, but it's certainly a great asset to patient care, and these are becoming more and more common in private dental offices as well. The CBCT is very nice.
So we'll focus on the lower left of this image. This is a coronal section of a CBCT. Let's look specifically at the 4/8. So you can see the little red line and the green line show the hash marks showing the position where they intersect of the inferior alveolar neurovascular bundle, sitting just to the lingual aspect of the 4/8 root. So in a panorax, all you would really be able to see is it's traversing it. This tells me it's on the lingual aspect. So if I get down and I'm dealing with a root tip, I'll know it's okay to drill on my buccal aspect of that root tip with my 701 burr to help facilitate the extraction in a safe fashion. Crush injuries are another potential source of nerve injury, completely avoidable by converting a difficult extraction into a surgical extraction. So while at the outset of surgical extraction, the thought of raising a flap, making a trough, and sectioning a tooth might seem more invasive, depending on the relationship of the tooth to the nerve, like on the previous slide, that's the only option for that tooth. To elevate a tooth out like that, even if you could pull it off, would be the worst thing you could do for that nerve. It's going to crush it on the way out, create an ischemic injury, create a neuropraxia or a permanent anesthesia or a dysthesia. It can all be avoided with an open surgical approach, with the segmentalization of the tooth, taking it out in multiple pieces and putting zero pressure on that nerve, thereby almost eliminating the risk of a crush injury. Here you can see a tooth that even if you wanted to elevate it out, if you put your 77R where the yellow dot was, in order for the crown to come up, the roots must go down, thereby crushing right through the neurovascular bundle. So this is why we opt to surgically remove most impacted teeth, because it's the least traumatic to the associated neurovascular bundle. If you don't have a CBCT and you see the roots traversing the inferior alveolar nerve, I think it's reasonable to pack that patient up and refer them to somebody that does have a CBCT. Before this was an option, we would often use surrogate markers of how close is the actual root to the canal based on is there loss of the white lines around the inferior alveolar nerve, so loss of cortication. Is the inferior alveolar nerve canal narrowed? Is there a band of radiolucency across the roots of the third molar? And these would be, say, surrogate markers that they are in an intimate contact to one another and at increased risk of nerve injury. Now, as soon as I see it traversing the IAN, I just get a CBCT and find out exactly the relationship, as opposed to going through these 3 steps to determine, how safe I am. Even if I know it's close by, I don't know if it's buccal or lingual, and the only way to get that is with some 3D imaging. If you see the nerve ruptured at the time of extraction, that is a very good indication to refer for reanastomosis. Short of that, if the patient calls with altered sensation in the post-op period, there's typically not many good indications for surgically exploring it, opening it up. You're more likely to cause more harm than good, and typically you're going to want to see that patient back on a regular basis, make sure there's no signs of infection, optimize the conditions for healing, and map out their area of sensory deficit and follow them along regularly. And typically it will slowly recover over time, indicating that it was a neuropraxia, plus or minus an axonotomesis. And the likelihood of a permanent deficit is exceedingly rare, but this is what you need to discuss with your patient prior to doing anything. So I often quote my patients around 1% or less, depending on the tooth, of a permanent numbness to the lip, chin, and tongue when taking out the lower third molars. Injuries to the TMJ. Certainly a lot of patients out there with TMJs that don't function perfectly well, and very common history to hear trips to the dentist, mouth being open a long time can precipitate or exacerbate underlying temporomandibular joint disorders. So good to be cognizant of patients' TMJ health TMJ level and quality of function, and accommodate to it. So if a patient needs the odd break or can't be opened quite as wide, then provide that for them. Maybe split things up into shorter appointments. Like everything else, it's all about prevention. Now, the potential complication is something that we now call MRONJ. It used to be called BRONJ, or bisphosphonate-related osteonecrosis of the jaw. But now there are other medications out there that essentially have a similar function as bisphosphonates, but aren't actually bisphosphonates, but still affect bone turnover. So now is a bigger, more encompassing umbrella term called medication-related osteonecrosis of the jaw, or MRONJ. Was first described back in 2003 by Marks after noticing necrotic bone on a series of patients that had never had radiation, which if they had radiation, they would typically call it osteoradionecrosis. These are patients that had never had radiation but still had necrotic alveolar bone. And eventually they pieced it together and realized it was the common denominator was the fact that they were all on bisphosphonates. These medications are either taken orally, typically to prevent osteoporosis, or they can be administered IV, typically to prevent hypercalcemia in the setting of metastatic bone malignancies, like metastatic breast cancer, prostate cancer, or multiple myeloma. Some of the medications to be aware of on your patient's med history would be things like alendronate or Fosamax, which is taken orally. Ibandronate or Boniva, which is also taken orally. Risidronate, Actonel, very common, also taken orally. Some of the IV ones are Pamidronate, or also known as Iridia, Zolendronate, also known as Zometa, and another IV medication. One of the newer ones is denosumab, which is a rank ligand inhibitor, which is one of the examples of one of the non-bisphosphonate but still affects bone turnover, which is why it's not called BRONJ anymore. It's called MRONJ, medication-related osteonecrosis of the jaw. In the setting of oral bisphosphonates, the risk of MRONJ is relatively low. The risk increases significantly with IV bisphosphonates, and the risk goes on for some time due to the long half-life of many of these medications in the matter of years, up to 7 years at some point. So every effort should be made in the setting of IV bisphosphonates to carry out more conservative treatments, root canals, for instance, instead of extractions. And if you're forced to do an extraction, through careful surgery, primary closure, smooth the rough edges, and cover the patient with perioperative antibiotics, and follow them back regularly to keep an eye out for medication-related osteonecrosis of the jaws. In closing, important to understand that complications do not necessarily imply negligence. Complications are to be expected from time to time, and these are the things we're talking about with our patients with respect to consent. Malpractice, on the other hand, is defined as negligence on behalf of the dental practitioner who failed to meet the standard of care. The standard of care being that level of care provided by a reasonable practitioner of similar skill and learning, practicing under the same or similar circumstances and in the same or similar location and time. Preventing your complications from becoming malpractice litigation has a lot to do with communication, which starts at the outset with consent, but then also afterwards, seeing these patients that have had these complications, not avoiding them, but getting them in and following them up on a regular basis and consulting when appropriate. When patients feel like they're left on their own with their neuropraxia or their dry socket or their infection, that's when they really start to get frustrated. So make sure you're available. Anytime you do surgery on a patient, the patient should be able to get a hold of you. It's very reasonable for them to have your cell phone. Not joking. You'll be impressed with how infrequently patients will call, and when they do, you're very happy that they were able to get in and see you for a timely treatment, instead of suggesting they go into the regular emergency room waiting 3 hours only to get referred off elsewhere because the emergency department is not equipped to deal with post-operative dental surgery complications. In conclusion, complications are going to happen. You need to be aware of this. You need to educate your patients. Be proactive. I say at the first sign of any of these complications, get your patient in and assess them ASAP. They'll thank you for it. It's the right thing to do. It's a great practice builder. Patients will be very happy, and they'll really appreciate the fact that you are doing the right thing. It'll be quite rewarding to be able to manage your own complications instead of finding out after the fact that they went into emerge and they got referred to the hospital and you don't find out till 2 weeks later. It's very unrewarding. So make yourself available. Communication is key, and expect complications and deal with them and create a relationship, a professional relationship with a oral maxillofacial surgeon, so that when you encounter something that you do feel is over your head, you have the comfort level to pick up the phone and say, hey, so-and-so, I have complication XYZ, want to pick your brain, or refer them in